Section 11. Addressing gastrointestinal side effects in antipsychotic treatment. I'm going to be discussing sialorrhea and constipation. Sialorrhea is drooling from impaired swallowing, the pool and drool hypothesis, and not necessarily from increased production of saliva. You will see sialorrhea in people who are Parkinsonized from dopamine blockade, and you really need to treat the Parkinsonism in order to reduce sialorrhea. Clozapine is a special case. It's common and very vexing, also in part related to impaired swallowing, but people are not clinically Parkinsonized. It's not just a cosmetic problem. It can be stigmatizing, can lead to carotid swelling and parotitis, and to aspiration pneumonias. The pathophysiology is seemingly paradoxical. It's really not hypersalivation, but it's a swallowing problem too. And you would not expect this because clozapine is also very anticholinergic. But it turns out to be complicated because there are muscarinic receptors and also alpha-adrenergic receptors responsible for this. And there's a circadian aspect to sialorrhea in clozapine patients as well. How do you manage sialorrhea in clozapine patients? Therapeutic drug monitoring may play some role, so if you can reduce the dose, it may help a little bit. In severe cases, Botox injections can play a role, but before you go to Botox, consider glycopyrrolate, despite the possibility of anticholinergic problems from glycopyrrolate. But in general, topical approaches would be better. We could use sublingual atropine, the 1% drops, 2 drops up to 3 times a day, or the sublingual ipratropium 0.06% spray, 2 sprays up to 3 times a day. So for most patients, you'll be able to manage with the topical approaches and therapeutic drug monitoring. Constipation is a problem with many patients, whether they take antipsychotics or not, so keep that in mind. There's a baseline problem, but antipsychotics can cause gastrointestinal hypomotility. This is in of itself not problematic, but you could end up with an ileus or ischemic bowel disease, and it's fairly common in treated patients, at least 30%, but it may not be a sensitive marker. In a national cohort study from Taiwan, constipation was mostly associated with clozapine and quetiapine, again suggesting that it's not just clozapine, but other antipsychotics as well. The treatment here is a high index of suspicion and a prophylactic bowel regimen. Let me make a few more comments though on clozapine-associated constipation. The FDA strengthened the warning about the side effect because we have focused so much on agranulocytosis and really missed the possibility that constipation can progress to serious bowel problems, bowel obstruction, and that this may actually be more common and lead to more hospitalization and death, the agranulocytosis. The risk increases with higher doses and with concomitant anticholinergics. In terms of clinical guidance, try and evaluate bowel habits prior to clozapine. As I said, constipation is a management problem for patients in general, and then monitor the bowel function throughout treatment. The problem is that asking about constipation is not a sensitive measure of the true effect of clozapine on gut motility. Clozapine equals a slow gut. That should be your guiding principle when you think about how to manage it. So you want to educate patients about constipation prevention in general. Exercise, great. No bulking agents should be used, or fiber supplements. A lot of people intuitively reach for those. Instead, you should consider a prophylactic bowel treatment, and the Porerua protocol is one that is most widely used in the field. Examples would be a combination of a daily stool softener plus a weekly and as needed stimulant laxative. And then you may need to step up your management with linaclotide or lubiprostone. Key points. Gastrointestinal side effects from antipsychotics include sialorrhea, which results from impaired swallowing, the so-called pool and drool hypothesis. Sialorrhea, which stems from less frequent or impaired swallowing, is most pronounced with antipsychotics who cause Parkinsonism, and as a special case with clozapine. Treating sialorrhea is important not only to avoid stigmatizing patients, but also to prevent recurrent aspiration pneumonias. Constipation is a potential side effect of any antipsychotic, particularly with clozapine. It can be life-threatening if an ileus develops with bowel perforation. One should assume that all patients on clozapine have a slow gut and that their self-reported constipation is not sensitive. Proactive management with a bowel regimen that includes as a minimum a standing stool softener and regular stimulant laxative is good clinical practice.